Okay. So we've got allergy, we've got transfusion reactions. Now think about this. When your immune system becomes superactive, hyperactive, generally how we call this autoimmune disease. So actually those of us who have allergy, we can proudly claim that we do have autoimmune disease because it is autoimmune. However, the majority of really severe autoimmune diseases, they employ different mechanisms. Mostly, autoimmune diseases are mediated by type 3 and type 4 hypersensitivities. Type 3 hypersensitivity involves the formation of so-called immune complexes. In this instance, your B cells produce immunoglobulins, mostly immunoglobulin G, that bind to your own antigens. And those immune complexes, so you see that's the immune complex. Those immune complexes, they get lodged in the basement membranes. Membranes that separate epithelial cells from the connective tissue. So if we want to draw schematically layer of epithelial cells, then at the basal surface there's going to be a basement membrane, and here there's going to be a connective tissue. Does it make sense? So these immune complexes, right here, they get lodged in that basement membrane. Now remember, antibodies by themselves, they don't do anything. They just label. But what they label for is destruction. So presence of immune complexes in basement membranes will lead to the attack on those immune complexes from macrophages and neutrophils. This attack will destroy basement membrane and impair the integrity of endothelial cells. Does it make sense so far? What is the function of endothelial cells? Epithelial cells. What's the function of epithelial cells? Epithelium in general, what does it do? So connective tissue connects, muscles move, epithelium it separates. It separates lumen from a tissue. Epithelial cells that are part of the skin separate the environment from the tissue. Epithelial cells in your throat separate the lumen of the throat from the surrounding tissue. Epithelial cells that cover the blood vessel from the inside separate the lumen of the blood vessel from the surrounding tissue. They are barrier. Do I make sense? Now, if basement membrane it starts to get destroyed, there's an inflammation there, integrity of epithelium is damaged, and one of the classic examples of the diseases mediated by type 3 hypersensitivity is systemic lupus erythematosus, or lupus. In lupus, what does patient experience? Well, first, I wouldn't say first or second or third, just, like symptoms. Blood vessels. Endothelial cells, the cover of the internal surface of the blood vessels. Tunica intima becomes inflamed. Permeability of the blood vessels increases. Plasma starts to leak into the peripheral tissue. Do I make sense here? Also, since endothelial cells are quote-unquote damaged, platelets start to activate. In patients with SLE or lupus, they develop much more frequent cases of thrombosis. Second, what do we have? Heart endocarditis. Lungs, pulmonary edema, pretty much idiopathic pneumonia. So you have an inflammation in the lungs, accumulation of fluid in the lungs without any infection. Bones, I'd say joints. In synovial joints, like knee or elbow joint, synovial membrane produces synovial fluid. If synovial membrane becomes inflamed, synovial fluid accumulates, arthritis, joint pain. If it affects basement membrane in the skin, that may lead to eczema, other manifestations like that. And in the kidneys, it leads to the condition known as the glomerulonephritis, when endothelial cells in the glomerular capillaries become damaged and kidney function becomes impaired. Does that make sense? So you can see how antibodies to basically some protein of yours, they can wreak havoc, around all epithelial barriers in a human body. Now you have to appreciate that not all the symptoms are extremely severe. That's how we diagnose lupus. The symptoms start to accumulate. Patient experiences vasculitis, maybe joint pain, maybe some skin problems, shows up to the doc diagnoses it. There are certain antibodies that help to diagnose lupus. And then, what are the treatment options for autoimmune disease? Steroids, or anti-inflammatory, and in severe cases, specific immunosuppressants. And steroids will do just that. They will stop across the board. But what you want, if you can, you want to target a very specific mechanism. For instance, we'll talk about type 4, and then I will, mention the specific disease where we stop a mechanism. So type 4 is also called a delayed hypersensitivity. Obviously, delayed means that the immune response takes several days. Reason for it is mediated by T cells. And I'm going to talk about it using, as an example, TB test. Okay? So when you get TB test, you get tested whether or not you had an infection with the bug known as Mycobacteria tuberculosis. Because if you had this infection, then at the time of infection, your immune system responded to it and formed specific T cells after the initial response, exposure to antigen. Does that make sense? So then you come to the doctor, and doctor will take a needle and injects an antigen, so-called tuberculin, inside your skin. Dendritic cells in your skin, so-called Langerhans cells, will phagocytose the antigen and present it to CD4 cells that will differentiate into the helper cells. These helper cells will stimulate macrophages and cytotoxic T cells to go after those particular cells in the skin that carry this TB, tuberculin antigen. Does it make sense? And those CD8 cells, cytotoxic lymphocytes and macrophages, will start to destroy basically the part of the skin where the antigen was injected into. So you form that pustule, that fluid filled thing, right? Does that make sense? The more T cells you form, okay, the more macrophages or cytotoxic T cells you're going to form. The bigger the inflammation at the site of injection is going to be. That's why when you come back after a couple of days after the TB test, the nurse or the physician, they will measure the size of your TB test. And if it's above a certain threshold, it means that you have been exposed to tuberculosis and you had an infection. And you may have it like now. Does that make sense? Are we clear about it? Same goes with poison ivy. When you first time exposed to poison ivy, you don't know about it. That's your first exposure. That's when T cells are formed. When you're exposed to it second time, then when this response is produced, that is the moment when T cells and macrophages start to attack the skin that was exposed to poison ivy, causing massive inflammation and skin destruction and so on and so forth. Does that make sense? But so far, if you think about it, I've never had poison ivy, to be honest, but I can imagine that the damage from this is temporary. You're not going to have it forever. It's probably painful, very unpleasant, but it's temporary. However, there is a condition, human condition. It's called Crohn's disease, which is mediated mainly by these mechanisms. When T cells, macrophages, attack tissues in the large intestine, basically destroying the epithelial cells, leading to colitis, ulcerative colitis, malabsorption. There are several reasons. My very good friend works on this disease. My wife works in the lab that focuses on this disease, and my son's good friend has this disease. He was the only kid in the class that did not gain any weight in 7th grade because of malabsorption before he was diagnosed. Now, common treatments for diseases like that, as Kimberly mentioned, steroids, to inhibit immune system. However, there is a drug that goes specifically after this activation process. As you can see, one of the critical molecules that stimulate macrophage and T cell activation is tumor necrosis factor, TNF. It's one of the key mediators of inflammation in people. And quite a few, couple decades ago, some pharmaceutical company developed a drug. It's called Remicade. I don't know if you've heard about it. Remicade is the antibody that blocks tumor necrosis factor. Essentially blocking, so it kind of stops this. Remicade blocks the activation of T cells and macrophages, and it's a great drug. Seriously. It alleviates the symptoms of it slows down the progression of inflammatory bowel disease greatly. It's a fantastic drug. There are a couple of downsides to it. Number one is the price. I'd be honest, I don't remember the price. We're talking about like $1,000 or $3,000 an injection, something like that. It's terribly expensive. Okay. So I can tell when I was doing experiments, I needed this drug to do some mouse experiments. We were lucky. We basically got the drug that was expired from a doc that we knew in the department. Basically, it was almost illegal to the point of, never any prescription written, because we couldn't afford to get this drug, to buy it. It was cost prohibitive, really. Second downside, as you can imagine, any response like that, which involves activation of macrophages and cytotoxic lymphocytes, it involves TNF-alpha. tumor necrosis factor. So by administering this drug, you're not only alleviating the symptoms, the disease, you also cutting off the branch of adaptive immunity. Does it make sense? And this particular process is crucially important for protection against viral infections. Again, that kid that I know, he basically always has a runny nose. He's constantly immunosuppressed. I mean, don't get me wrong, he doesn't wear a mask or goes in the gown. No. But he basically always has a common cold. It just is like normal state because he's immunosuppressed and his immune system takes much longer to get rid of the rhinovirus. By the time he's better, he just catches another one. Okay? It's lousy lifestyle, to be honest. Okay? And the sad part is that we still have no idea how to deal with it. Like, we cannot cure it. It's terrible. Many autoimmune diseases are actually mediated by both type 3 and type 4 hypersensitivities. Say rheumatoid arthritis, type 3, type 4. Inflammatory bowel disease, mainly type 4 with a small involvement of type 3. Multiple sclerosis, basically equal type 4 and type 3. Okay? So in this case, we have to deal with both antibodies and T cells. So what I want you to know, I want you to match the mechanism with a type of hypersensitivity. That's basically the question that you can encounter. I give you like type 2 hypersensitivity is, okay? Does that make sense? And I gave you the examples. So we have general allergy as an example of type 1, transfusion reactions as example of type 2, lupus is the example of type 3, TB test and poison ivy as an example of type 4. Just know these examples. Am I clear? Can we move on to transplantation? I always tell, first of all, autograft. So there are 4 types of grafts. Autograft, self-transplantation, skin. That's the only option, really. Isograft. So lucky ones that have identical twin, ideally, I don't know if anyone has, but those who have identical twin, I suggest now it's good time to lure that identical twin into your house, into the basement, lock him or her up, and just feed and maintain healthy identical twin as the potential organ donor. Because identical twin provides you with same major histocompatibility molecules on the surfaces of the cells. No rejection. Does that make sense? It doesn't happen often, really, Speaking seriously, isografts are extremely rare. Just because chances of having an identical twin and, needing the transplant, it's not frequent. Okay? Allograft is the majority of grafts. It's a transplantation between people who are not identical twins, unrelated, complete strangers, mother and daughter, brothers, fraternal twins. My kids are fraternal twins. They are as genetically related as just brothers, okay, of different age. And what sometimes the weird thing happens is that the match between 2 complete strangers can be better than the match between 2 relatives. And for this, there's a huge database that is kept, database of people who need transplantation that is unfortunately constantly updated, because some people are added to this database and some people are removed, mostly because they die. There is a database of people that is also constantly updated, people who can give the organ. Some people give their organs being perfectly healthy. The student who donated a kidney to a complete stranger. I very much appreciate the act of valor, but from the personal standpoint, there's a reason you have 2 kidneys. There's a reason you have 2 lungs. There's a reason you have some organs impaired. Maybe liver donation may not be a bad idea, because liver tends to regenerate. So if you donate a piece of your liver, it'll grow back. But other than that, if you have 2 kidneys, one fails, you still have another one. You have 1 kidney, that's the only thing that you have. Does that make sense? Most frequently, though, the organs come from people who die. People who die in, say, different accidents. Organs that are, I don't want to say most valuable. I don't want to be perceived wrong here. I'm not putting the price tag on the organs. Say, organs that are most rare are children organs. So if the child is on the list, it's extremely hard to find a donor, because you cannot possibly squeeze the adult heart into the 4-year-old, for instance. Okay. It's interesting how the system works. If you know, yeah, you do have a certain hierarchy in the list of the people who need the transplant, but also there should be a match. The person on the very top may not win that particular kidney or liver because they may be a horrible match. And it's interesting that often there is an available, say, kidney. People would look through all the recipients, potential recipients, and find the match. There will be a lot of items for consideration. How badly it is needed, things like that. And it's a terrible decision. There was an example, great example, when kidney, I think it was kidney, was found, the kidney that was needed was found in Britain, and the recipient was in the United States. The best matching recipient. The kidney was flown by a military jet from Britain to the United States because of the time constraints. Not regular military, because it would cover the space much faster. It was a matter of a day, and they made it. Okay? So, time's important. And of course, the main problem with a solid organ xenotransplant from animals, very quickly, cardiac valves, mostly from pigs. Yeah, that's it. So the main problem is transplant rejection. Essentially, what happens during rejection, you have a antigen presenting cell, okay? Either antigen presenting cell that is left in the transplant in the graft, or antigen presenting cell in the recipient, no matter which one. They present antigen from the transplant to the T cell of recipient. And immune system of the recipient recognizes that it's an antigen. It's wrong. And it starts to attack the graft. How do we deal with that? Immunosuppression. Can it lead to the rejection anyway? Absolutely. And here's another problem, really big problem if you think about it. What if you have some kind of an infection in a transplant? Quiet infection. There was a terrible example when the person who died in, I think it was motorcycle accident, he had the organ donor on his driver's license. His organs were used for transplantation in multiple recipients. The only problem was that this person who died in the motorcycle accident at the moment was infected with rabies. There were no clinical signs. The virus was about to become clinically apparent, but nobody saw it. Several people, I don't remember, it was under 10, but like 5 or 7 people received organs from the person who had rabies. They all got immunosuppressants. They developed fulminant rabies virus infection, which is untreatable, and died very shortly after the transplantation. So now all donors tested for rabies. That's not the only example. Before, if you have hepatitis C infection, which can stay silent in you for years, and if you know that you have hepatitis C, that you tested positive for hepatitis C, you're not going to be able to donate organs. Now there are more and more calls to stop this practice. We have an extremely effective drug, or drugs should I say, that can cure hepatitis C. Basically, the idea is that somebody receives hepatitis C infected liver, okay, and then the recipient receives immunosuppression and the treatment against hepatitis, which increases the available pool of donors. Does that make sense? Awesome. Now, I specifically mentioned that transplant rejection is common for people who receive solid organ transplants. Another type of transplant in the bone marrow. That makes sense? Now, that's not solid organ. It's basically a blood transplant. So what do you have to do before you transplant bone marrow? When somebody receives a new organ, what do you have to do with the recipient first? Remove what? Yeah, you have to remove old organs. In this case, you have to get rid of the recipient's bone marrow. What is the function of bone marrow? What does it produce? Blood cells. So basically, you're getting rid of all blood cells, including immune cells. So make a person immunologically naive completely. And then this immunologically naive person receives the graft that's graft of bone marrow that starts to produce new blood cells. Red blood cells, platelets, and of course, leukocytes. Leukocytes enter the bloodstream, lymphocytes enter the lymphatic system. You know what they find there? They find antigen-presenting cells in the tissue that present to those lymphocytes from the donor bone marrow antigen that they have never seen before. And they think, oh, this entire body is our enemy. And they start to attack all the tissues. This is called graft versus host disease. When T cells of a donor attack the tissues of the recipient. The better the match, the less this disease is. Does that make sense? So basically, if you would decide to do it without any match, the person, first after the transplantation, the person would feel fine. Graft versus host disease develops slowly. But in about a month, the person would develop multi-organ failure just due to the autoimmune attack on everything. Then the person would die. That makes sense. So basically, in rejection, immune system of a recipient attacks the organ of a donor. In graft versus host disease, immune system of a donor attacks the body of a recipient. Am I clear? Treatment in both cases is immunosuppressive. This particular condition, graft versus host disease, is common consequence of leukemia treatment. My wife's former colleague, I personally know the guy. He underwent this particular treatment for leukemia, so he had a bone marrow transplantation. If somebody in the lab was sick, like common cold sick, he just left. He was allowed to because it was too dangerous for him. And he never bought any food in the cafeteria. He couldn't trust. And it's understandable. Okay, so he had always his own food packed, prepared. He knew that at least the only person to blame was him if something happens. Now, from super active immune system, we jump to not so active immune system. Jump to the immunodeficiencies. Let's get the acquired immunodeficiency out of the way. Acquired means the one that you get. Cancer is the typical acquired immunodeficiency. AIDS, of course. Acquired immunodeficiency syndrome, that's in the name. Less, known, measles. Measles virus reproduces in B cells and kills them. And for about 6 months, the person becomes immunosuppressed, immunodeficient. Generally speaking, any condition that affects your immune system can be considered an acquired immunodeficiency, whether it is temporary or permanently. Does that make sense? Acquired immunodeficiency is one that you we're not born with. We good? Clear? Moving on. And here we come to talk about congenital ones. They are fairly infrequent, so you're not going to find people with those conditions often. And what do you think? Which system is more critical? Which part of the immune system is more critical? Adaptive or innate? Huh? So you think if you hit innate, that's worse? That's what I'm asking. So what's gonna be worse? If you have problems with innate responses, or if you have problems with adaptive responses? What's the difference between those responses? Which ones are systemic, all over? Adaptive or systemic? So if you hit adaptive, you get rid of much more profound tool. Do I make sense? And there are multiple studies that show people with various deficiencies in the innate responses can live pretty normal life without any specific therapy. They have to be careful about certain infections. Many of them never get diagnosed, really, because they never experience any problems. Now, with adaptive system, there are two main issues. Either there are no T cells, or there are no B cells. Does it make sense? So in the condition known as DiGeorge Syndrome, T cells do not develop in the thymus. This condition is usually associated also with developmental abnormalities, including physical and cognitive abnormalities. So it's really severe condition, DiGeorge. Now, in case when there is no B cell development, the person cannot produce antibodies. Does it make sense? And it's going to impair immunity, but will not be as severe as the T cell deficit. All in all, people with DiGeorge syndrome they have pretty poor immune system. However, there's a condition in which stem cells of the lymphoid lineage fail to become precursor T or B cells. So basically, patients with this condition do not develop any adaptive immunity. This condition is called severe combined immunodeficiency, SCID or SCID. Ever heard about boy in the bubble? Stories about boy in the bubble. These people have practically no functional immune system. They have to live in a sterile environment, in a special enclosure. People that contact them have to wear personal protective equipment to prevent any possible transmission of anything. Now, is there any hope? Yes. I know stories of two. Not like, no, I mean not like day by day personally, involved in this, but one kid with this condition started to receive regular blood transfusions, and you can do it because basically you get somebody else's functional T and B cells, and they're going to work, He started to receive regular blood transfusions in his late teens and managed to live to his 30s. And he died not of the infection, he died of the kidney failure because of the regular blood transfusions and associated hemolysis. The toxicity to kidneys basically killed him. Second story is very, very sad, incredibly sad. The ultimate treatment for SCID is the it's a treatment, but how many can you get? So let's answer this question together. So if those lymphoid stem cells, cells that eventually will become lymphocytes, which organ are they coming from? They blood cells, so which organ are they coming from originally? Kimberly? Bone marrow. So if you replace the bad bone marrow with a good bone marrow, you can do it, right? So the match was found, bone marrow transplant. Yeah. This boy's match was his sister. And sister was ready to do anything to save brother. And they were like kids, like 13, 10, like ballpark this. So he gets all his bone marrow destroyed. Normally, his sister donates bone marrow. And the boy receives the transplant and everything looks great. And then he develops fulminant infection with Epstein-Barr virus. Imagine mono multiplied by 1,000 times, because the poor fella has no immune system whatsoever. Turns out his sister had mono years ago, and the virus became latent in the bone marrow. Nobody even thought about it. And the boy died in a matter of weeks because of that absolutely just horrible scale-wise infection. I don't even want to think about the sister's emotions. Parents decided to have another child, that another boy that had the same condition. The second boy died at the age of 6 months. Doctors pretty much told him just give up. They didn't, and got the third boy, which was absolutely 100% healthy. This disease is quite fascinating because it's sex-linked recessive, which means the mom of this boy had a phenotype with one chromosome being normal, and one chromosome, I label it red, carrying the recessive gene that was responsible for severe combined immunodeficiency. The boy's father was healthy. Okay? When sperm and egg, that kind of, after the conception, okay? In case of first two boys, the zygote had a karyotype, or, I should say karyotype, so had the boys had this karyotype. The disease gene carrying chromosome from the mom and the Y chromosome from the dad. Since Y chromosome did not have that arm that would block otherwise recessive gene, they had an infection. The third son had basically this karyotype. That's why he was completely healthy. Does that make sense? So for this disease, as for any other sex-linked recessive disease, women are carriers, but boys get sick. That's why the boy's sister, and she got tested, she was normal, so she got this. She was absolutely healthy. She got perfectly fine, bone marrow. And that's unfortunately the only option for the treatment of this disease. It's really like a very sad story. Anyway, so in regards to this, when you leave, there's a quiz right here. Few administrative, as I call it, administrative things. So I will start the discussion of lymphatics. We're going to finish lymphatics on Wednesday. We'll do the study guide review on Wednesday, and we will do the exam on Monday. Okay? The exam is going to be only physiology. I remind you, there's no anatomy component. The lymphatics anatomy component will be moved to respiratory as we usually do. You will see, it's like ridiculously small. So basically, lymphatic system, it's a sewage. Fluid spills out of the capillaries into the tissues. From the tissues, it enters the lymphatic vessels. You can see them labeled in green here. Okay. Lymphatic vessels shown in green. They collect the fluid from the tissues and bring it back into the blood. Somewhat lymphatic vessels similar to veins. They're thin-walled, they basically do not constrict. They have valves, okay? And so what happens, it starts all with the capillaries. So this is the typical lymphatic capillary. So these are the endothelial cells of the lymphatic capillaries. Can you see this? So that's an endothelial cell. Now you can see that they arranged in a flap-like manner, so like this. So when fluid starts to accumulate in tissues, the valve's open. Does that make sense? Like a flap is open. Fluid flows into the lymphatic system. From the lymphatic capillaries, goes to the collecting vessels, then to the trunks and to the ducts, and it ends up in the blood. It actually drains into the veins here at the merging point of the jugular and subclavian veins. Does that make sense? So all that lymph ends up in the heart. That's how fluid is returned back to the circulation. Are we clear about it? Now, so far it sounds absolutely pointless, honestly. Think about this. Like those capillaries, they collect fluid and then bring it back to the heart. What's the point? On the way of that fluid are lymphatic organs, spleen, a bunch of lymph nodes. You can find the most notable ones where? Where would you palpate the lymph nodes? Cervical? Where else? Axillary? Groin. Yep. So those, now don't take it as there's a fourth place which we rarely check, popliteal region, behind your knees. Okay, so those are like 4 close to the surface, a lot of lymph nodes. The function of lymph nodes and spleen is to basically filter the lymph. Think about them as the miniature water treatment plants that remove all kinds of crap from the lymph, clear it up basically, and then cleared fluid enters blood back. Does that make sense? Can we find lymphatic everywhere? No. So you can see bones and teeth have no lymphatic vessels. Bone marrow has no lymphatic vessels. And CNS. Now with CNS you have to be careful. What are the parts of the CNS? Brain, brainstem, and spinal cord. There are lymphatic vessels in the brain, though. They were discovered about 3 years ago. And it was, think about this for a second. Think about this for a second. We're talking about like 2015 or 14, something like that. Discovering a major structure in the human body. Anatomically. We didn't know that they are there. It was huge. It was really a huge deal. So we know now that there are lymphatic vessels going through the brain. Okay? So, brainstem not, spinal cord not, maybe yes. But I mean, never saw them. Brain, yes, we do have lymphatic vessels in the brain. There's a special type of capillaries, we talked about them, lacteal. Right? Does that make sense? Remember. Now, those capillaries emerge and form collecting vessels that look very much like veins. And they often run along the arteries. Actually, it helps to propel the lymph. When arteries pulsate, they basically squeeze the lymphatic vessels and push the lymph, up. Now, along with the big organs like spleen or lymph nodes, there are other organs of the lymphatic system, which we should mention. Thymus, talked about it, produces T cells, right? Matures, not produces. That's where T cells mature. And there are a lot of lymphatic tissue in mucosal regions, mucosal parts of the hollow organs, so-called mucosa-associated lymphoid tissue. There are tonsils in the upper respiratory tract. There are Peyer's patches in the intestine. And if you would look at the location, you see the difference. When lymph runs through, it systemically collects the trash from all body tissues, and then lymph nodes and spleen filter this trash. Does that make sense? Tonsils, Peyer's patches, mucosa-associated lymphoid tissues, they can be found in the walls of whole organs or around the whole organs. Respiratory tract, a lot of microorganisms can enter through this. Digestive tract, a lot of microorganisms can enter through that. That's why you're going to have lymphatic tissue concentrating around the potential entry sites. Did that make sense? Good. So you're going to wrap it up.